All right, I'm ready, Dr. Kurtzman. Are you ready?
I'm all set.
All right. Well, thanks, everyone. I appreciate joining our panel this evening. We've got a great presentation lined up for you, a terrific speaker. My name is Rich Groves. I'm the VP of Professional Affairs for the Next Media Group, and the Next EDS is proud to bring you a really informative session tonight. That's in concert with our friends at Sunstar Americas, who have provided a great educational grant that enabled us to bring you a fantastic speaker and an informative session, so we appreciate their support of this activity. It's being brought to you as members of the Next EDS exclusively. Dr. Kurtzman is an expert in this particular field and several others. Published more than, if you believe this number or not, more than 500 articles in the professional literature on a variety of topics. He's a very well-read and well-published authority in dental implants, in prosthetic dentistry, grafting, and this particular aspect of periodontal therapy. He spent a lot of time, and this last summer has published several peer-reviewed articles on the topic, and is going to bring that information for you in the next the course of this particular hour. I'm going to let Dr. Kurtzman have the wheel in just a few moments, but before we turn the controls over to Dr. Kurtzman, I just wanted to let you know that we're going to present for about 40 minutes in didactic fashion, and you can answer questions or pose any feedback you'd like to have Dr. Kurtzman address at the end of our session. You can use either the chat function or the QA session, and we'll pose all of that as we wrap up and let him kind of answer in real time at the end of the hour. We're going to ask a couple of polling questions along the way. We'd like to have your feedback and understand some of the things that affect you as future caregivers, so we hope you'll take part in those and allow us to see what your thoughts are about the future of periodontal therapy and oral biofilms. If you have any questions, feel free to send me a note in the chat, but otherwise, it's my pleasure to introduce you to our speaker tonight, Dr. Greg Kurtzman.
Thank you. This is part two of the oral biofilm and the systemic connection, and we're basically going to talk about some of the systemic effects of oral biofilm. Oops. So they get this to change. I guess it is not. Let's see. Hold on. There we go. A little bit about me. I'm private practice. I'm a general practitioner in Silver Spring, Maryland, which is outside of D.C. I've been a CE junkie for many years since dental school, and I've participated in a lot of stuff. I have published a lot of articles on various things. I guess you could say I'm a dental idiot writing savant. That's my hobby. Don't get into sports and stuff, but I do like writing. So let's talk about this. In part one, we talked basically about the oral biofilm, the inflammation, the oral health relationship. And what we're going to do basically, as you can see in part two today, is talk about systemic effects of oral biofilms, cardiac, arrhythmias, kidney, pulmonary, diabetes, colon, some oral cancer stuff. And then we'll go into part three next time and talk about more systemic effects, prostate, pancreas, liver, pregnancy, fertility, Alzheimer's, artificial joints. And then we'll wrap it up in part four. We'll talk about these first three parts. Now, what do we do? How do we treat this, and how do we improve our patients' lives and live healthier lives? So basically the agenda today is we're going to basically review a little bit about, we're going to talk about the systemic connection of oral biofilm. We're going to move into cardiovascular disease, then into kidney disease, pulmonary disease, talk about some diabetes, and as we said, oral, prostate, and colorectal cancers. And it's interesting because when I graduated in 1986, and probably prior to me starting dental school, we were really tooth mechanics. Everything between the lips and the back of the throat, we treated. Anything beyond those points, it just wasn't in our realm. And when I started dental school, things changed. They started giving us more medicine related education, and I think it's gotten much better over time. And we started recognizing that what goes on in the mouth affects the rest of the body. And what we used to call plaque, basically, is, now we realize it's much more complex, and we're really referring to it as an oral biofilm. And we've sort of borrowed the term biofilm from the medical world. And basically that just means it's a sticky matrix with bacteria of different types that are sort of working in conjunction with each other, turning genes on, turning genes off. And basically it's a thriving community that protects itself. and it's able to basically regulate things in the body to do that. That's why antibiotics really don't work well with biofilms. They do work with photonic bacteria. That would be bacteria coating the surface. But once you get them into a biofilm, they really don't do too much. We can't really treat them that way. But it does have some effects on the body. And as we see, there's a lot of accumulator research. We look over the last 20 years, we're seeing more and more of this coming out. And as I was putting these PowerPoints together for the series, I kept stumbling on more and more articles that were coming out almost, it seemed like on a daily or weekly basis, talking about the evidence-based links between periodontal disease, chronic oral inflammation, and multiple health conditions like respiratory disease, diabetes, osteoporosis, as we said, cardiovascular, and a host of other things. And we do realize, as I said today, that plaque is a complex environment. We've retermed that oral biofilm. And I think the benefit of students that are graduating now or going through dental school is you're getting a lot more of this education than I did when I went to school. And people that graduated before me really got very little of this. So I think you're really a benefit. We're in a materials and science evolution in dentistry, and we're growing by leaps and bounds around what we can do. So let's look at the systemic connection. Harmful bacteria, strains, and the oral biofilm can enter the bloodstream during the inflammatory process and travel to other areas of the body. This exerts a distant systemic effect that has been linked to numerous diseases, cardiovascular disease, respiratory diabetes, as we've said, and evidence, let me just close this for a second. Whoops, I hit the wrong thing. Okay, there we go. Evidence indicates that patients with periodontal disease have a much higher risk of developing other systemic problems, and that's all related to the biofilm and how we control this. So as the biofilm matures and proliferates, soluble compounds produced by pathogenic bacteria penetrate the sulcular epithelium. These compounds stimulate host cells to produce a chemical mediator associated with the inflammatory process. And that's basically what we've always known. The bacteria that's in there causes periodontal disease, it causes inflammation in the tissue, moves into the bone, and basically resorbs the bone. But what we really have started over the last 20 years understanding is those effects go beyond what's supporting the teeth, and they reach far areas in our body. So mediators recruit neutrophils to the area via chemotaxis and cause increased permeability of gingival blood vessels, permitting plasma proteins to migrate from within the blood vessels into the tissue. As the gingival inflammatory process continues, additional mediators are produced, and more inflammatory cell types such as neutrophils, T cells, monocytes are recruited to the area. Pro-inflammatory cytokinins are produced in the tissues as a response to this chronic inflammatory process. And these proteins may further escalate the local inflammatory response and affect the initiation and progression of systemic inflammation and disease. So I'll leave this next part to
Mr. Grove. Thank you all for attending. We really appreciate it. Dr. Kurtzman's got a great rest of the presentation underway. Apologize for breaking in the action, but we're going to ask you a quick poll, if you don't mind. I'd like to ask you very quickly, let's do this. I'm going to open a quick poll. What patients have, when patients have periodontitis, approximately how much more likely are they to have some other impact on their overall health? Let's see what your feedback is here tonight. Now, we know that it's an interesting trend. Dr. Kurtzman's even published on some of this information as recently as this summer. Leave that open just a little while longer to let the rest of you participate. Thanks so much for sending in your reaction here. We're going to post those reactions in just a second so you can all see. Okay. The countdown, you've got about 15 more seconds if you want to provide feedback here. Okay, everyone, here's what that looked like. Okay, Dr. K, let's take it away.
So let's talk about cardiovascular disease, because that's really a big thing. More people in the United States die from cardiovascular issues than any other process. So basically, cardiovascular disease is an umbrella term for heart and blood vessel conditions such as atherosclerosis, coronary artery disease, stroke, myocardial infarction, as a result of a complex set of genetic and environmental factors. And the interesting thing is that, we can, genetics, I think, plays a big factor. And we can basically play with the genetics a little bit to favor things, and we can basically really ignore it and let things get much worse. So genetic factors include age, lipid metabolism, obesity, hypertension, diabetes, family history disease are going to basically make us prone to these things. But environmental risk factors also play key components, and we do have some control over most of those things. Socioeconomic status, how much we exercise, how much stress we're under, our diet, smoking, chronic infections. Classic risk factors such as hypertension, hypercholesteremia, and cigarette smoking may only account for about 1/2 to 2/3 of the incidence of cardiovascular disease. So classic risk factors such as hypertension, hypercholesteremia, and cigarette smoking may only account for 50 to 66% of the incidence of cardiovascular disease. So we basically, we have some control, as we said. We have no control over our genetics. It's what we're dealt. But we do have some factors that we can play with. We can get exercise. We can try to de-stress a little bit. So we can play with a little bit of these things. There's increasing evidence, though, of linking chronic infection and inflammation to cardiovascular disease with the biofilm as a predisposing factor. And the connection between oral bacteria and cardiac disease is not a recent development in the literature. Oral bacteria, specifically Streptococcus mutans, which is cardiogenic, and Paromonas gingivalis, which is what causes periodontitis, induce platelet aggregation leading to thrombosis formation. One more of the periodontal pathogens, as reported in the literature, are found in 42% of erythromas in patients with severe periodontal disease. It does not want to move. Not moving. Oh, there we go. Reported that P. gingivalis actively adheres to and invades fetal bone, heart endothelial cells, and aortic endothelial cells. Additionally, a 14-year study found periodontal disease patients at a 25% higher risk to develop cardiovascular disease than their healthy counterparts. Men younger than 50 years with periodontal disease demonstrate a 72% more risk to develop cardiovascular disease. And additionally, periodontal disease increased risk for both fatal and non-fatal strokes by 2-fold. Despite the strong evidence of an association between periodontal disease and cardiovascular disease, it is unknown if this is a causal relationship. So we're starting to really learn things, but we don't have all the pieces in the puzzle. Periodontal disease releases bacteria that may enter the circulation, invading the heart and vascular tissue, causing harmful effects. People with higher levels of bacteria in their mouth tend to have thicker carotid arteries, an indicator of cardiovascular disease. And bacteria near diseased gingiva appears to induce clumping of blood platelets, which can lead to clotting and blockages, which can lead to heart attacks and strokes. So we can see it's all interrelated. The body's response to periodontal infection, including production of inflammatory mediators, which travel through the circulatory system, may cause harmful effects on heart and blood vessels. And inflammatory mediators such as lipoproteins, triglycerides are significantly higher in patients with periodontitis than in those control groups. So we can see basically on the diagram here what a normal heart looks like, and there's one with plaque buildup and fat, and we can see the blood vessels accordingly. So we basically have, as we're saying, we have some control over things, and some things we don't. We're sort of, in a sense, we have to play the cards we're dealt, but we can play with those cards a little bit to increase our chances of not having these problems. Increased levels of C-reactive protein, a biomarker for inflammation, is associated with periodontitis, shows increased clotting, which is associated with an elevated risk of heart disease. Periodontal disease emergence as a potential risk factor for cardiovascular disease is leading to convergence in oral medical care. I think that probably in another generation or two, maybe 20 to 30 years, we're going to have a definite connection between dentistry, what we're doing in the mouth, and the rest of the body, where it will be one big healthcare thing, and it will basically, we will be the specialists dealing with the dental stuff, but we will really be part of medicine at that point. Proper management of the oral health may very well be key to prevention of cardiac disease or worsening of existing heart conditions. So let's go into kidney disease. Cardiovascular disease and chronic kidney disease share many risk factors with periodontal inflammation linked to the development of kidney disease. Pathogens found in oral biofilms have been shown to have the ability to adhere to and invade coronary endothelial cells, leading to arthroma formation and impaired vascular relaxation. And we basically, we're finding a lot of connections, as we've said. Similar effects are noted within the vasculature of the kidney. Symptoms of diminishing kidney function are nonspecific and may include feeling generally unwell and experiencing reduced appetite. Chronic kidney disease, identified by increased levels of blood creatinine, indicate a falling glomerular filtration rate and decreased kidney filtration rate, waste products. So as it's basically progressing, we're seeing decreased kidney function. Chronic kidney disease, most common causes are diabetes mellitus, hypertension, glomerulonephritis, which together cause approximately 75% of all adult cases. Chronic kidney disease patients are characterized by few well-established risk factors of periodontal disease, including poor oral hygiene and diabetes. So we can see how everything's kind of interconnected. Periodontal disease, kidney disease, they basically all interconnect, and it's all with the factor that links them is the bacteria in the mouth. A strong correlation appears to exist between patients on dialysis and the higher number of patients suffering from gingivitis, 46%, and severe periodontitis, 35%. The correlation appears to be bidirectional, as patients with chronic kidney disease have a higher prevalence of periodontal disease. So maybe in these cases, what we have to do is we have to educate our medical brethren and say, hey, look, you got a patient who has kidney problems, we have to get their mouth in shape. We have to maintain that as best as possible because it's going to help on the other end. And they have to basically understand this and educate the patient saying, hey, look, you're having a kidney problem, you have diabetes, cardiovascular disease. We need to involve the dentist and we need to clean the mouth up and keep it clean. Pulmonary is also a big one. Periodontal biofilm is a reservoir of bacteria and a source of lower airway infections, especially in older patients or those who are debilitated. We're going to see a lot of this in nursing homes. We see patients that are in their 70s, 80s and up, and people living a lot longer, usually wind up, what kills them is pneumonia. Where is that coming from? It may be coming from the biofilm in the mouth that's aspirated into the lungs, and therefore leads to an infection, leading to pneumonia. So the problem is that those patients are in the nursing homes, or even if they're home, they're not getting the care, they're not taking care of their mouths, they're not taking care of the removal of prosthesis. All the stuff is growing on it, and it's very easy to aspirate this. Oral biofilm can inoculate the respiratory tract, as we said, when aspirated. Severity of the disease is correlated with the pathogenicity of the bacteria in the biofilm. And I see a lot of, probably about 35% of my practice is geriatric, and I see a lot of these patients basically, over the 31 years I've practiced, wind up getting pneumonia as they get older. They have respiratory issues. And it basically, sometimes it, kills them, and sometimes it doesn't, and, they go on in debilitated health for a little while longer, and eventually their health declines to the point where they really can't live any longer, and they wind up passing. Maybe we can do something to help with that. Periodontal pathogens and cardiogenic bacteria increase the risk factors for aspiration pneumonia. So the severity of the disease is correlated with the pathogenicity of the bacteria in the biofilm. The highest risk patients for respiratory infection, bronchitis, and pneumonia are medically compromised patients, as we said, with or without respiratory disease, who are unable to perform adequate oral hygiene. The problem is these patients either don't have the manual dexterity when they're living on their own. When they're in nursing homes, it's even worse. And the nursing staff, unfortunately, does little to help them maintain their mouth, especially if they're wearing dentures. They basically say, well, they don't have any teeth we have to worry about brushing. The dentures really don't get cleaned very often. And they're building up this biofilm, which can easily be aspirated. Highest risk patients for respiratory infection, bronchitis, and pneumonia, as we said, are medically compromised patients. Evaluation of 328 articles published over an 11-year period, basically linked oral hygiene to oral health care, associated pneumonia, or respiratory infection in elderly patients. So there's a lot of evidence showing this. The key basically is maybe we need to educate nursing home staff and say, hey, look, this is what needs to be done. You know, we need to basically do a little bit more care. We need to make sure their dentures are cleaned. And say, you know, a lot of the older patients do have removable prosthesis. We're seeing less of this because people are taking better care of their teeth. But we still see a lot of patients with partials or full dentures. Evidence that mechanical oral hygiene practices reduce the progression or occurrence of respiratory diseases in high-risk elderly people in nursing homes or hospitals. So basically, it comes down to education. We have to educate these people. We have to educate the families of these people so they go in and they push the staffs. You know, you have to take better care of mom or dad or whoever it is, family member, making sure that their oral care is taken care of. Mechanical and oral hygiene practices may prevent the death of about 1 in 10 elderly residents of nursing homes from healthcare-associated pneumonia. Proper oral home care is critical in preventing these infections by minimizing the potential of aspirating the biofilm into the pulmonary system. And as reported, oral hygiene intervention significantly reduced the occurrence of pneumonia in institutionalized subjects. Frequent toothbrushing and preoperative use of 0.12% chlorhexidine mouth rinse or gel reduce nosocomial or respiratory tract infections. And it may be soaking these dentures overnight in these things, making sure that they're scrubbed off. Even if they're not scrubbing them, maybe the soaking will help. It's going to help decrease these things. So placing all elderly patients on chlorhexidine daily rinses as a preventative measure may be recommended to aid in preventing potential aspiration pneumonia. This has demonstrated the use of low concentration peroxides, and we'll talk about this when we get to part 4 and how to treat a lot of these things, in custom trays that have a positive effect on oral biofilms, thus reducing the bacterial load and decreasing pathogenic material that may be aspirated. This may be a more predictable approach in elderly patients who lack manual dexterity to perform oral care with a toothbrush. So we can basically give, say, hey, an electric toothbrush is better than a hand toothbrush, but a lot of these patients don't even have the ability to use an electric toothbrush. And as we said, the aides taking care of them tend not to spend much time on this. It's not an important thing for them unless we push them. Elderly tend to also be denture wearers, as we said, high incidence compared to younger populations, and can be susceptible to aspiration biofilm growing on those dentures. As this patient population has decreased immune systems and an increase in systemic diseases and issues, they are particularly susceptible to pulmonary infections, which could be induced via the bacteria within the biofilm attached to that denture. And as you get into practice, you're going to see, and you may be seeing it in dental school, patients come in, elderly patients, you have them take their denture out, and it looks like that denture has not been out of their mouth since the last time they saw you maybe 6 months ago. They're just caked with stuff. It's all bacteria and everything else. They're just not doing a very good job. So we have to make it, if we make it easy for them and for their aides to do this, and it may be soaking it in stuff like chlorhexidine and other things, we decrease the chances of them having those pulmonary infections due to the biofilm. And if it's easy, there's more likelihood it's going to get done. So this becomes more problematic in nursing home settings, as we said, for those patients unable to care for their own denture due to either physical or mental limitations. Immersion in a peroxide-based cleanser solution effectively reduces the quality of microorganisms surviving on that denture. So we basically, and I think that unfortunately using Standard denture cleanser tablets is probably not enough to really break this stuff down and clean it. We need something that's a little bit more aggressive with the biofilm that's adhered to these appliances, but is not going to degrade the appliance itself. Those patients who are unable to mechanically scrub the dentures would benefit from immersion of the denture in a peroxide solution, such as found in over-the-counter in any drugstore, and that could be just standard 3% hydrogen peroxide. Peroxide breaks down the biofilm very effectively. It just sort of dissolves it, where other things do not necessarily. You put it in with Efferdent or one of those other denture cleanser tablets, it gets a little bit of the surface, but it's not really going to break it down as effectively. And this can be performed daily by nursing staff or home care aides to help prevent potential aspiration of biofilm in those compromised patients. We'll move on to diabetes. Diabetes is a significant public health problem affecting 29.1 million patients, which is 9.3% of the U.S. population, with an estimated 8.1 million. That's 27.8% of patients going undiagnosed. Most people that have diabetes just never get diagnosed because they ignore the symptoms and they just keep trucking along until something really serious happens. When it comes to their attention, at that point, usually the diabetes is fairly far advanced. Those patients with diabetes have twice the risk of periodontal disease than those who don't have this metabolic disorder. Periodontal disease is more prevalent, prognosis progresses more rapidly, and it's often more severe in patients with type 1 or type 2 diabetes. Periodontal disease has been classified as the sixth most common complication of diabetes and is a well-established risk factor for severe periodontal disease. And basically, whenever I see a patient who comes into my practice and they've got periodontal issues, and I'm not really seeing a lot of plaque and stuff and tartar on the teeth, but their gums are just not in very good shape, if I don't see the plaque, I say, well, I know they're using a toothbrush. And if I don't see that plaque and calculus on those teeth, I start suspecting that there's a possibility they may have diabetes and it's just undiagnosed. And a lot of times you'll ask them and you go, yeah, I have it. How well controlled are you? And usually you get the shrug. Well, I don't know. It's up and down. So you have to explain to them, it's like, you take care of your mouth. It helps the diabetes is not as severe. If you have diabetes, it basically makes your periodontal worse. So if you take care of one and the other, they sort of feed off each other in a sense and you get healthier. Patients with periodontal infections have worse glycemic control over time, and this have greater difficulty managing their diabetes. You get a patient that comes in, basically says, they just can't get my diabetes under control. Let's take a look at your periodontal condition. I do see some perio issues here. That might be the factor. Get those perio issues under control. That may help them get their diabetes under control. Treatment of periodontitis appears to improve glycemic control. Thus, control of the periodontal infection and associated biofilm should be part of the standard treatment in diabetic patients. Colon cancer. Colon cancer annually kills 50,000 people in the U.S. a year. Yet the link to an oral connection of periodontal disease via the biofilm is just becoming known in recent years. The bacteria Fusobacterium nucleatum, found in the mouth and in periodontal disease, has a role in periodontal disease. This bacteria has also been shown to colonize the gut and attach to cells in the colon, triggering a sequence that can lead to colon cancer. So we can see what's going on in the mouth travels elsewhere in the body. Reported that patients with periodontal disease have a much higher levels of this bacteria than those that with normal periodontal status. Although a possible association has been found between oral infection and colon cancer, a cause and effect relationship has not yet been found. Published studies show that F. nucleatum can speed the accumulation of cancer cells, minimizing this bacteria by controlling and management of the oral biofilm may lower the risk of those patients who are at increased risk of colorectal cancer. Oral cancer. Oral cancer ranks sixth amongst the common malignancies globally, with a rising titer of around 40% in developing countries such as Southeast Asia. Amongst those, 90% of all oral cancers are squamous cell carcinoma, originating from mucosal epithelium. Although etiology for 78% of oral cancers has been majorly linked to betel quid tobacco chewing, which is a nut, smoking and alcohol consumption, other factors like genetic susceptibility of the individual, external factors such as dietary factors may exert their synergistic effect in tumorigenesis. And it's interesting, you always have to look at the ethnic background of patients and see, well, what's going on with them? Is there an ethnic link to these things? And I had a patient years ago who came in who had a history of oral cancer. And she was of Indian extraction. And the first time I saw her, and she was telling me her history, and I said, do you use betel nuts? And she said, how do you know about that? I said, well, they taught us that in dental school. And she says, yeah. I said, you're still using them? She goes, yeah, my family, they come over here, they ship them to me and everything. I go, did your doctor ever, your oncologist ever talk to you about that? He goes, no, he's never asked me. So I said, you know, maybe that's a factor there because there is a high link there. So we have to look at the ethnic backgrounds, the and other things that are in that cultural group that may be affecting these things. 15% of oral cancer patients have no known risk factors, and the disease in this population may pursue a particularly aggressive course. This may be attributed to infections involving viruses like human papillomavirus, HPV, and Epstein-Barr virus, fungi like Candida albicans, and certain bacteria. And what we're doing is, if you look at oral cancers, we're seeing less cancers caused by smoking and other things because people aren't smoking as much. People, you know, really aren't drinking as much as they were 10, 15, 20, 30 years ago. But we're seeing the total level of oral cancers has not really changed. But we're seeing them in different parts of the mouth where we didn't see it before. And when they culture these things, they're finding in a lot of these cases HPV. So close to 43,250 Americans will be diagnosed with oral or pharyngeal cancer this year. This will cause over 8,000 deaths, killing roughly one person per hour, 24 hours per day. Of those newly diagnosed individuals, only slightly more than half will be alive in 5 years. Poor oral hygiene has been recognized as a possible risk factor for oral and pharyngeal cancer. One theory suggests that chronic infection, such as periodontitis, may promote normal cells to mutate. The inflammatory process signals cells to proliferate. The more proliferation that occurs, the more chance there is of mutation. The mutation of cells takes a long time to occur, so eliminating risk factors such as poor oral hygiene can halt that process or at least greatly slow it down. If the periodontal disease remains untreated, our body adjusts to this heightened inflammatory state, which makes our immune system less responsive. It's sort of like walking into a room and you smell something, and after about 5 minutes, you don't smell it anymore. You get used to it. And the body is the same thing. There's a lot of inflammation going on in the system. It basically starts ignoring it, saying, well, this is normal. I'm just going to ignore it. So over time, the immune system can suffer irreversible damage. And this damage is believed to be a key factor in the link between periodontitis and oral cancers. Researchers found inadequate oral health to be correlated with oral human papilloma HPV infection. Poor oral health is a new independent risk factor for oral HPV infection. A growing number of studies indicate that the presence of periodontal disease results in significantly higher risks of oral cancer for those who smoke and consume alcohol than those who don't. The good news is the risk factors are modifiable by maintaining good oral health, good hygiene, and basically eliminating some of these things like HPV infection. We can try to manage those things. And the benefit now is that younger people that have really grown up in the last 20 years, they have vaccines that if you get it when you're young, you may be greatly reducing your chance of getting HPV infections and the subsequent related cancers from that. So in summary, increasing evidence linking chronic infection and inflammation to cardiovascular disease with the biofilm as a predisposing factor. The body's response to periodontal infection includes production of inflammatory mediators, which travel through the circulatory system and may cause harmful effects of the heart and blood vessels. Oral biofilm can inoculate the respiratory tract when aspirated. Severity of the disease is correlated with the pathogenicity of the bacteria in the biofilm. The elderly tend to also be denture wearers, and therefore they're more susceptible to aspiration of biofilm growing on the dentures. And individuals with diabetes have 2 times the risk of periodontal disease than those without. treatment of periodontitis appears to improve glycemic control in those diabetics. So as we said, if you have a diabetic who's having trouble controlling things, perhaps we need to look at getting their perio in better shape, and that may be the factor that helps them get the diabetes under control. So management of the oral biofilm may lower the risk for those who are increased risk of developing colorectal cancer. Poor oral hygiene has been recognized as a possible risk factor for oral and pharyngeal cancer. Chronic infections such as periodontitis may promote normal cells to mutate. And maintaining good oral hygiene, good oral health, one can prevent HPV infection and subsequent HPV-related cancers. So we're, I guess, 5 minutes ahead of schedule. So if there are any questions.
There are always questions, Dr. Kurtzman. Thank you so much for walking us through that informative presentation. We really appreciate it. Got a number of things that are already coming in, and if you don't mind us picking your brain for a little bit, I'm happy to tee up some of those questions for you right now. First question is, what's the feedback of some of the associations? What's their role in advocacy or funding research? What are the AAP and others in the professional space? What are they doing about some of these relationships that are being detected?
I think that, the AAP has really, because of the biofilm, is really a perio issue. I think that they've really started out sooner than some of the other organizations in getting involved with this. They've seen the link, they've looked at the science. I think that the ADA has jumped in behind them. I think the oral surgery groups have jumped in also. So I think that we're seeing a lot of discussion among these groups that they're looking at the science and they're basically saying, hey, there is a link, we have to do something. We're not just tooth mechanics anymore, we are healthcare providers, and what we're doing helps other things that are going on in the body, and we can prevent things or at least make them less severe if we control things in the mouth.
That's great. That's great. One of the questions I've seen come in a couple of different formats. I'm going to see if I can summarize in a way that maybe best describes. But the word link seems to be a very deliberate choice that everything in the literature is established, and yet everybody's commenting on similar tendencies. How isn't yet a causal relationship been established? Well, what has to happen in order to have the scientists and researchers come together on that point?
Well, I think that, the problem is that in order to have a positive link with something, you have to have a large enough population that's been affected and you're able to put the things together. So you basically, let's say for diabetes, we basically say, hey, we have 1,000 diabetics, and out of the 1,000, we have how many of those have periodontal problems? And then we start comparing it to non-diabetics. And then we start basically putting the numbers together and saying, all right, well, we see diabetics have tendency to have more perio problems than non-diabetics. So as time goes on, the pieces start coming together and we start linking these things. Some of the stuff is cause and effect, and some of it has not been proven yet. But I think that we're going to probably see over the next 5 to 10 years a lot more of this stuff falling into place.
Is there a certain density on that data that makes it suddenly applicable? I mean, the scale of these patient populations is pretty vast in a lot of, when you start to point to some of the numbers of affected patients.
Well, I think part of the problem is, and this is just personal opinion, that unfortunately the drug companies make more money treating the disease than curing the disease. So they're going to basically not really invest as much money into finding these relationships, because if you say, hey, as a perio relationship, we're going to have people that don't need as much diabetes medication, don't need as much cardiovascular medication. So I think it's been a slow process, really funding a lot of the stuff, but I think that it's falling into place, and I think that we dentists are really leading the way. We're pushing these things, saying, hey, we see these things. I have a patient, they were having all these diabetes problems. I keep going back to diabetes because it's a good example, and we got their perio under control, and next time I see them, they're telling me, hey, their blood sugars are great. They're like, they taper back on the medicine. Everything's going great. They feel better. So we basically, I think, are leading the charge in a lot of ways.
I have a question from Judy that says, given the patients in your practice, do you have a different kind of approach for a patient who is elderly and a denture wearer with periodontitis versus someone who is, let's say, middle-aged and has periodontitis?
I'll give you a perfect example. I had a patient in today who is 86 years old. We were able to save some teeth. I actually extracted 12 teeth on him today. left 12 teeth, and everything is totally packed. He hasn't been to the dentist in a few years. His wife nags him, which I guess is his wife's job. And she basically, I said, look, if we're going to save these other teeth, he's got to basically start taking better care of them. And that means getting rid of all this food and, for lack of a better term, crap that's all over the teeth. And that's why he lost the teeth. And maybe that's why, he's having health problems. So you really have to, the problem is it's habit. And if, it's hard to get into a habit. I have another example. I have a patient who's a friend of mine who came in with perio issues. We got everything cleared up. I scaled him, I root planed him, I laser treated it. We put him in perio protect trays. Last week I said to him, so I haven't seen you in 8 months for a recall. You're supposed to be on 3 months recall. Well, I got tired of doing this, and I have to use these trays 3 times a day. I go, oh, you just put gel in it and stick it in your mouth 3 times a day. How hard is that? Yeah. I know. I said, you want to keep everything, you got to make it a habit. You got to have it over 50 years not doing something. You got to make it into a habit now to do it, to take better care of you. It's a simple thing. I'm not asking you to do a complex thing. And he said, yeah, he agreed with me. So you basically, it's retraining people to get over bad habits to do better care. And unfortunately, as we get older, it becomes harder and harder to do that. We lose the mental and physical abilities really to take better care of ourselves.
In your practice, who's having those conversations with the patients? I think this came up in part 1 of the series too, Dr. Kurtzman. Is it you who's having the conversation with the patients? Do you rely on your dental hygienist for that? What's the split in your group?
Well, I like to have the hygienist start the conversation. I want basically when she sees things going on when she's doing the cleaning, she's basically pointing these things out. And then when she comes to get me, she says, oh, I saw these things in Mrs. Smith. Then I come in and I'm basically reinforcing this. When you hear it from 2 different people, you tend to basically pay attention more. You hear it from one person, especially when you hear it from the dentist. The patient's saying, "Well, yeah, he wants me to do all these things because he's going to charge me more money." The hygienist, she's an employee. She doesn't make any more money if I do whatever treatment we get. So they tend to listen to the hygienist better than they do us. But what we want to do is we want to reinforce what the hygienist is telling them. So they're basically seeing these things and they're understanding, hey, I'm hearing it from 2 different people. Maybe I need to do something. And sometimes you repeatedly have to do this. You see them every 6 months and it may take 2 or 3 years and all of a sudden the light bulb goes off and they start doing something.
I know that we're going to talk treatment in part 4 of the series, and please do continue to follow along with us, folks, so that you have a chance to get an in-depth coverage of this particular question. But can you talk to us a little bit about your standard protocol when you start to detect, because a lot of what you're talking about is behavioral modification. What's your chairside approach?
Well, basically we go in and I use this analogy in the first part of the series. I usually, when I see bleeding in the mouth, or the patient says, yeah, when I brush my teeth, I got a little blood, and they shrug, what's the big deal? And I usually say, if you brushed your hair and there was blood on the hairbrush, would you think that's normal? And of course, they go, no. And I said, well, why would it be normal in your mouth? Bleeding anywhere is not a normal sign. It's a disease. It's a sign of a disease process. So you start reinforcing subtly that something needs to be done. I basically will, based on what the patient's feedback is giving me, I may push in a little bit more and may push less. It depends on how receptive the patient is. And I realize that sometimes I have to say this repeatedly. Like I said, every recall, and finally the light bulb goes off and says, I'm ready to do something. And it's the same thing with treatment planning. You say to a patient, hey, this tooth really has a large filling and we should crown it. Oh, it's not hurting. They may go on for like maybe a year or 2, and all of a sudden they decide, I think I do need to do something. So we're educating them, we're giving them the information, and we're trying to change their behavior. And it's sometimes an easy process. Some people they come to the mountain and they're ready to learn, and some patients are like, I don't want to hear it. I had a patient I see him every 6 months. He's had a tooth that has been grade 3 mobile, looked like it was going to fall at any moment. Every time I see him for a recall, we just take this tooth out so you don't aspirate it. It's like he shrugged it off. He came in a couple of weeks ago, and he goes, oh, that tooth? I figured he was going to tell me, all right, I'm ready to extract. He goes, oh, it fell out the other day. I'm like, I've only been after him for sometimes it's not worth them. I hope that answers the question.
I think he did. Do you have a different recall protocol for a patient that when you start to see symptoms that are affecting more than just their mouth, when you're talking about an oral cancer patient, somebody where you can detect some signs of maybe diabetes, do you change your follow-up approach? How do you connect with your fellow healthcare professionals in that discussion?
Well, usually what I will do is if the patient has, we always ask them, who's your physician? And if they're basically telling me, if they're telling me that with diabetes, again, perfect example, I'm controlled, I have no issues, and they're usually fairly honest with that. I usually say, all right, we're going to see, if no perio problems, I'll see every 6 months. I see some bleeding and stuff, I want to see every 3 months. If I start seeing a period where you're not getting bleeding, we'll stretch it back out to 6 months. If they're having these health issues, I may say, I think I should talk to your physician, and let's try to get on the same page. And it's like, and I think physicians are becoming more receptive, the younger physicians are becoming more receptive to us being involved in the healthcare. Unfortunately, older practitioners that are 60 and above still look at us as tooth mechanics, and they don't want to hear anything. What is that? What is the dentist now? So, sometimes it's trying to educate them, but and I've had patients where, a good example, I had a patient came in, and she had a mole on her arm. And, I would go have that biopsy, go see a dermatologist. Oh, yeah, I'll go see my dermatologist. She goes in, the guy snips it off and is ready to toss it in the trash can. And her husband jumps up and goes, no, the dentist told us we had to have that biopsy. And the dermatologist said, well, what does the dentist know? All right, I'll do it. Came back with malignant melanoma. So as I said, I would rather than wrong, but he was saying, I got your dentist, what does the dentist know? So sometimes, and he was an older practitioner, sometimes we're seeing that, but the younger practitioners, I think, look on us differently.
That's an interesting generational point that hopefully our guests this evening run into more of those open-minded practitioners. Do you like electronic records? What do you share with those individuals? Is it just a phone call? How much of the patient's history are you sharing with the professionals in that interdisciplinary approach?
I want people to try, so I'll usually try to send an email. This way, I'll give you another example. A patient came in who's had a history of tongue cancer. Comes in, he needs new dentures. I'm looking, his tongue looks really weird to me. I take the Velscope out. There's an area that looks weird. I contact his oncologist. I send him a picture, and I said, this area looks really strange to me. The guy gets on the phone, I had my in yesterday. It looks fine. I said, no, we don't need to biopsy it. My answer was, can you email that or fax that to me because I want it from my record? Because I don't want something to happen and then the patient turns around and says, why did you miss this? I said, no, I identified it. Your physician who's treating that for you chose not to listen to the advice. So the more paper trail we have, the better. I think we have a lot more documentation we can do these days for oral cancer. We have the Velscope and other things that we can look at an area, take a picture, or we just have a regular camera, and then we could basically, when they come back in 6 months or 3 months for the next recall, I can take another picture and I can compare the two and say, yeah, it hasn't changed or has changed. Now we need to look at, send you to a specialist that looked at. So I think we have a lot more avenues to document things about these days and testings and share that information with our brethren.
That's great. I have a couple more for you, Dr. Kurtzman. In layman's terms, what's the approach you would use to describe for your patient the link between diabetes and periodontal disease? What type of word choices? How do you get into that discussion?
I think everybody knows the term bacteria. I said there's bacteria in your mouth, under the gums. You can't really get to it with the toothbrush. And that basically is getting through your system. It travels with chemicals of the bacteria, or the bacteria themselves, go out through your whole body. And when your part of your body is weakened, whether it's cardiovascular or diabetes or something like that, it sort of centers in those areas and can play a factor. And if we get 22 and everything cleaned up in your mouth, this may help your other conditions. So it's basically, you really have to talk in layman's terms to the patient because then they understand it. And giving them analogies, like the hairbrush thing, so they can understand these things, because otherwise the patient's sitting there nodding their head up and down because they're going, if I tell him I don't know what he's talking about, I'm going to come across as stupid. So obviously he's telling me this, he must think I understand him. And I'll always say, do you have any questions? Does that make sense to you? Just to make sure that, encourage them to ask questions. but give them analogies, talking very basic layman terms so they understand what the connections are. Because most of the time the physicians aren't doing that. They're just saying, well, this is your problem. Here, take this medicine, and that's it. And they go, okay, and they're taking it. They really don't know what the connection is with anything else.
Interesting. I think we covered that, Nicole, but if you would like a follow-up, just please let us know. Dr. Kurtzman, I have a follow-up just based on one of the things that you mentioned that was interesting to me. When you're examining your patients with the Velscope or other detection devices for oral cancer, is there a certain sign that sets you into motion, or what percent of your patients are you scanning every day right now?
If I see an area that looks suspicious, I'm usually using that. And that basically, usually it's a non-painful area. You look at an area, it looks red or looks white, it looks indurated, it's sort of dimpled in, and the patient says, no, that doesn't hurt. That usually says, because cancer usually doesn't hurt until it's really the end stages. So usually what I'm saying, and I think the Velscope out, and for those who aren't familiar with it, it's been used in pulmonary and vaginal exams. What happens is, when you turn it on, it's a special fluorescent light. Active areas are going to show up as dark spots on there. So if I see an area, let's say on the side of the tongue, which is a common area for cancer, and I basically shine that on there, everything looks green for the light, I don't see any black areas. I said, that was fine. I think it's just probably trauma. We're not going to worry about it. We'll look at it. I'll get you back to 3 weeks. Look at it again, see if it's changed. If I see a black area, that's telling me there's something going on there just below the surface, and basically we're just catching it in the early stages. And the good thing about some of these devices is we can catch things very early on versus it really advancing a lot before we identify it.
Fantastic. I think if that's, I think we've queued through all the questions that we've received. Dr. K, if you wouldn't mind just taking us through that very next slide so we can talk a little about what's on tap for parts 3 and 4. All right, folks. I'll just kind of tease out part 3. Dr. Kurtzman is going to be talking about additional systemic effects on other parts of the body, as you see on our presentation right now: prostate, pancreas, liver, pregnancy, some women's health issues, Alzheimer's, and artificial joints. There's so much research and across the various fields. We really hope you'll come and join us for part 3. We'll have a similar didactic portion and follow that up with a Q&A just as we have tonight. And then part 4, I think, has been a topic about 3 weeks from that, where we've been exploring some ideas, particularly in the question and answer session. I'm trying to understand some of the best therapeutic approaches to take with patients who are seeing these effects across their body, their oral condition, et cetera. And so I hope you'll come join Dr. Kurtzman and I as we continue this to the next two sessions on parts 3 and 4 in November. All right. On behalf of our sponsors,
and if you do have any, I was going to say, if you have any questions,
okay,
feel free to email me, drimplants@aol.com. Any questions on perisystemic health or anything dentistry? I won't answer anything on politics, sports, or religion. 2 of those get me in trouble. The other one I know nothing about. But feel free to reach out to me. I am email junkie and I'm always on Facebook. So I hope you've gotten some information out of this and you've enjoyed it. We'll see you for part 3.
Thanks so much, Dr. Kurtzman. We appreciate your time tonight. We thank our sponsors again at Sunstar for making this possible. And certainly we thank all of you participating for your great questions, for your attention tonight. And we hope you'll join us again in just 3 weeks from now. Hope you have a great rest of your evening, and thanks again for your time. We appreciate it. Good night, everyone.
Good night.